Good morning, everyone. My name is Benicio Gonzales, and I work for the Center for Health Equity in Louisville, Kentucky, and that's part of the Louisville Metro Department of Public Health and Wellness. In June of 2006, Dr. Adewale Troutman who is a public health scholar, began the Center for Health Equity. And it was the first Center for Health Equity housed within a municipal government at the time. So nearly now we're approaching our 10-year anniversary. And in late 2015, Dr. Brandy Kelly Pryor was appointed as our new director. And Dr. Kelly Pryor has a joint appointment with the University of Louisville and the School of Public Health and Information Sciences. She was originally scheduled to be here today and sends her regrets that she's not able to be with us. Today, the Center for Health Equity, in the Center for Health Equity, we want our work to go beyond having conversations about health disparities, but instead supporting projects and policies and research that work to change the correlation between health, longevity, and socioeconomic status. So we want to change the context about how we work to eliminate health inequities. And so a major project of the Center for Health Equity is our Health Equity Report, the HER. And in this report, we detail social determinants of health as they're known. And so what this does, in our previous reports produced in 2011 and 2014, we look at health outcomes across Louisville's many neighborhoods and areas of demographic diversity. And so the report describes for residents in our community what neighborhood and sub-neighborhood and a trend analysis of these social determinants of health are and health outcomes across our city. So many of you might be familiar just with the concept of social determinants of health. If you're not familiar with the concept, think about it this way. If you go to the doctor, right, the doctor says, hey, we gotta make some changes to your diet, maybe get a little bit more exercise, okay? Social determinants of health are some, not all of them included here. So might say where your doctor is probably not going to tell you, let's explore whether or not you have an adequate income or employment opportunities. What are your transportation needs? Your doctor's not talking to you about those things, but these things actually have a greater impact on our health. And so that is what we are exploring at the Center for Health Equity. And so the Center for Health Equity has, the Health Equity Report has three main objectives. One is to portray current social, economic, and environmental factors associated with inequity in health. Two, to assist local organizations in facilitating community dialogues about health inequities, focusing on the root causes rather than just individual behaviors. So this is a familiar map that you would find in our Health Equity Report and other maps like this that you'll see, which are detailing here the age-adjusted life expectancy by neighborhood and neighborhood groups in Louisville, Jefferson County, Kentucky. And finally, our report has as a goal to encourage community-based actions related to social, economic, and environmental determinants of community health. And these actions then are based on the information and the story we present in the Health Equity Report. Which brings us to talking about what story have we been telling in this Health Equity Report. Again, these maps are a familiar theme. So we know that how we analyze, organize, and prioritize the data and the issues that we present in the report is critically important. In recent months, as we've begun our planning for the 2017 Health Equity Report to come out, we've begun to ask ourselves some questions. So we've asked ourselves, what do we need to stop doing? What should we continue doing in the next report? And what must we start doing in the next report, which we have not previously done? So here's what we know so far. One, that our reports are devoid of personal and community stories which contextualize and humanize the data which we present to the community about itself. So the result is that these maps that you're seeing before you, and many others like it, are left to tell the story, the complex story about health, inequity, and opportunity in our city. And secondly, that while the first report utilized community engagement to drive the composition and the content of that report, our 2014 report was, that process was entirely absent. So for the 2017 report, we know that we must work to cultivate a community-based approach which will amplify the community's voice, experience, and power to move the needle towards equity. And we've often framed this work, we think, in terms of empowering communities, right? So advancing life for women and men and our whole community, instead in doing this work of the health equity report. So here's this information and you can use it in the community. Instead of us thinking about how do we have the community drive the story that we are telling here about equity and opportunity in our community, and letting that story drive our work as a Center for Health Equity. Additionally, because of how this report is used across the community with decision makers, academics, nonprofits, corporations are picking up this report. We know that. So how are we providing a way for the community to drive the story that is here, and therefore then letting that drive what our community members and decision makers are doing across the city? So that's what we're looking at now. So what haven't we been talking about? We know that that there are issues in how we collect this data, or what data we're collecting, and the story that we're framing for the Louisville community that we both work for but also are a part of. So, for example, in the 2011 and 14 reports, there are less than a handful of references to gender in our report. And each time it's mentioned like this, which is in a list of social determinants, but it is not otherwise explored throughout the report. Each report in 2011 and 14 mentions gender identity once. Additionally, there is no other exploration of sexual orientation or gender identity in either of the reports. And beyond some mention of racism in the 2011 report, there is not further exploration of other systems of power as it relates to health, even though we describe these things as social determinants. The 2014 has exactly one reference, and you are looking at it, has exactly one reference about Black women. That is it. This is the one time that we mention it in our entire report. And so, and additionally, there is no other mention of non-Black women of color in our report at all. And so part of our presentation here is really about holding ourselves accountable and calling ourselves out in this work, because we are the people representing a local government who are charged with advancing health equity in our city, and we have not been telling a complete and accurate story. So we are here as a part of this process to gain some insight from all of you as to what we ought to be paying a little bit more attention to, because we want to be elevating community stories to advance community health. We want to be more expansive in how we present complex issues of social determinants of health and the social determinants of equity. And central to this work, we think, is incorporating narratives which bring forth the realities and lived experiences of women of color in our community. And I've been thinking about Melissa bringing in the words of Tiana Gaines Turner earlier this morning, and in Tiana's words, talking about what state and federal governments ought not to do. Well, I represent a local government, and local governments ought not to do that as well, which is to be doing work supposedly about the people, and not having people be a part of the process. So we're here as an accountability measure for ourselves. So what are we going to do forward, moving forward in the 2017 report? We want to cultivate a community story. So on this side, closer to me here, you see the maps that we're familiar with presenting to tell the story about equity and opportunity in our community. And we're having to evaluate what is the way then, a community-based approach by which we might tell this story. So in recent weeks, we've begun a community conversation initiative with a goal of holding up to 26 conversations across our community. And to date, we've held community conversations with groups such as some out-of-school young people who, in a pilot conversation. Additionally, we've held a conversation with some men who are involved in, as a part of an NAACP chapter who are also incarcerated in the Kentucky State Reformatory. So one of our goals with this work is to hold conversations with diverse groups of women of color, and we're gathered here to explore with you how we might craft those conversations and our outreach. Currently, we have potential partners in sororities in our community, the Center for Women and Families, which is a local nonprofit which provides support to people who have experienced intimate partner violence and sexual assault, as well as some academic partners, especially with the University of Louisville with that joint appointment for Dr. Kelly Pryor. We really welcome your input. On your tables, I've placed some copies of this piece of paper here with some cards in order to contact us, but also detailing what are the outcomes and the social determinants that we've previously covered in our health equity reports. So anything from alcohol and drugs to diabetes, et cetera, to social determinants, education, employment, mobility, cost of living. We seeking your insight as to what are some of the other questions that we might be asking in our community conversations in order to center women of color in our health equity report. So what we're considering, what we're thinking about already, and what we're learning in the few conversations that we've had is in one area known as Shively in our community. A young woman talked about Bandhan and vacant properties in that community, which is something that we already talk about in our health equity report. But what we might find in a community conversation is not just the way that is having what we talk about general health outcomes, but I think others have mentioned fear and stress in the neighborhood. This young woman detailing the ways in which that dictates when she goes to the store so that she might experience or not experience street harassment and other forms of violence on the street on her way to the store. In another neighborhood, we've had a conversation and detailing the ways in which community planning may dictate who has the opportunity to access that neighborhood and who has the resources that they need and are made available to them within a community and neighborhood setting. And finally, as we're preparing for a conversation in an area of the Louisville community in which there's a higher population of immigrant persons, and in our conversation with a council person there detailing the ways in which a young person at a community event she was with was detailing the ways in which she's scared that her father and her uncles may be at risk for detention and deportation, and how that fear and stress is driving her daily reality right now. So we really are looking for your insight into what questions we might be asking in these conversations. What are the issues, even if we're already covering them? What are the types of more specific detailed issues and stories we might be presenting in this report? Again, because what we present here, first, the way that we craft it will dictate what is presented. And then what is presented, we know, is used by decision makers. These are policymakers who will pick up this report and use it to guide the decisions that are being made in Louisville. And in our community, then, often what is happening in Louisville can drive what is happening in the state of Kentucky. So we have a great opportunity here and a great responsibility, and we're looking for your insight as a way to do that. If you're willing to write any of your ideas on this piece of paper and you want to leave it on the table, I'm happy to come and retrieve those. If you'd like to be in contact with me in another way, also my card is there. I welcome any opportunity to discuss with you this work. Thank you.
So it strikes me that what we've just heard is something of an exemplar of what collaboration looks and sounds like. And as I was just thinking about T's presentation, a couple thoughts. One is, you know, as researchers and as scholars, we submit our work to journals or to conferences, and we receive the comments, and then we make a course correction, right? That's the standard practice. But I think what you're saying is something that's really critical. What if we, of necessity, submit our work to communities for their annotation, for their editorial comments, for their suggested revisions, and that be part of the process of policy making as well as knowledge generation. So I think that's what you've invited us to do here as well, and that's why I say it's an exemplar of collaboration. But let's open it up and see if there's some responses, questions, engagement for T, with T.
You might have mentioned it in the report, but I didn't see it. I might have missed it. I didn't see anything about mental health and what resources are provided there. And I think about it very often because my brother was diagnosed with bipolar disorder, and we realized probably in his late 20s that some of the issues that he was dealing with as a teenager and later in life were because of that, and affects so much of what we've talked about in the last 2 days. So I just wanted to know if that's something that you all consider and address in your report.
Yes, thank you for that. You're absolutely right. In either of our reports, we have not talked about mental health. And in our planning conversations for the 2017 report, one of the things that we believe we have under an absolute that we must start is talking about mental health issues in this report, but not just about, where are there instances of that, but the equity aspects of that. So who has access to care? But additionally, what are the societal and economic factors that are driving mental health issues? So we have to speak to that from both angles. So you're absolutely right, and it is absolutely something that we must start to do in our 2017 report. Thank you.
So I would like to just add, within mental health, a lot of people leave out the drug and alcohol piece as well.
Yes.
Also, sorry, we're on the subject of mental health. So one of the big things, well, obviously there's a huge stigma within the Black community about counseling and therapy and things like that. It's kind of like, shameful and these things, and we have to break through those stigmas in itself. But mothers are often forgotten, and postpartum depression is such a real thing. It is life-altering. It is insane, and if you've ever experienced it, you wouldn't wish it on your worst enemy. And I feel like there's such a lack in support. Women are killing themselves, they're killing their babies, and they don't have the necessary support. So if you're going to add mental health to your 2017 research, please, dear God, add postpartum depression as well.
Absolutely, and I think what you're talking about too, just the mere visibility of it at all, right? It's not something that we talk about often in the public space. So absolutely, postpartum depression.
Thank you.
curious, like Kim said, this is a really amazing model for you to come in and say, we are here to hold ourselves accountable. And so I'm wondering if you, and Dr. Pryor, as you were working to do this, to say, we see that something is missing from this report over years and we want to fix it, within a local agency, encountered resistance, if there was a process that you had to go through. So if other folks wanted to do this where they live, if there's things that you navigated that you could guide other folks on how to do it, because I think it's an amazing model.
Yeah, so I'm, hi, Dr. Kelly Pryor. I think she's watching on the live stream, so I'm trying to think about what I'm going to say here. You know, the truth of the matter is that because of how we have done this process before and previously so far, is we've been the ones deciding. But if we change our process, then the community will be deciding. You know, in public health, you know, one of the things that is reiterated in terms of how do we operationalize equity, how do we get to equity in our work, is again and again about that community participation and community engagement. We can advance ourselves in terms of working towards equity, the thing that we are charged with doing, but the thing that as a staff we feel passionately about, and also be a model to the rest of our department, and we hope to the rest of our local government departments as well, as this is a way that government ought to be working, right? And it's good for equity, to advance us towards equity. You know, I feel grateful Dr. Kelly Pryor again couldn't be here, but this is our talking as a staff about how we're going to do this. So I think part of it is, like, sometimes leaders forget that they have power to shape how a process is going to work, and leaders forget that the job is to include everyone and make sure everyone's coming along. And so Dr. Kelly Pryor, I think under her new leadership at the center, we're able to say this is a part of how government ought to do its work. So leaders remembering that they have power, I think, is the answer. Yeah.